I'll be talking about the Performance 2 trial. The main disclosure here, as you just heard, I'm the inventor of the device, so please keep that in mind as I go through the data. I'm going to keep this on label and data driven. So over the last 2 decades, we've seen, as we see with all technologies as they mature, in improvement in outcomes. What you see over here is a reduction in death stroke over 30 days in various trials over the last 2 decades as technique, operator experience, operator volume, patient selection, improved stent design has come into place. Over the last 2 decades, outcomes after carotid artery stenting have continued to improve as well, not surprising. That being said, every single randomized trial done to date comparing endarterectomy to stenting, as you just heard, has shown the same thing, which is that death between the two, endarterectomy and stenting, is the same, major stroke is the same, but minor stroke has always been higher for carotid artery stenting as compared to endarterectomy, regardless of the strategy for carotid artery stenting that's utilized. In this case, which filter or which stent used didn't matter. The outcomes were the same, always a higher risk of minor stroke with carotid artery stenting. So we set out to understand, why is this happening? Why is this Achilles heel there? What can we do to address this Achilles heel of higher minor strokes? In order to do that, we had to understand and try to dive into when do strokes occur, because if we're going to invest time and effort into reducing this risk, we need to understand where the risk is maximal. And so there are 3 main phases of the procedure. There's access, there's the procedure itself, which includes multiple steps, and then post-procedure, once the procedure is done and the patient goes home. And the question was, is this risk equally distributed? And so as we looked into this, we found that strategies that enhance procedural embolic protection resulted in very low 30-day stroke rates. For example, proximal occlusion, whether you use MoMA or if you use flow reversal by TCAR or the Gore flow reversal device by Perotti, when you reversed flow or stopped flow or enhanced procedural embolic protection, regardless of the type of stent you used, whether it's open, closed, or mesh covered, it appeared that the risk of stroke was down in the 1% range. So that was very interesting, and to us that provided robust clinical evidence that if you enhance procedural embolic protection and you were getting lower rates down to the 1% range, then that must be a very important contributor to 30-day event rates. So armed with that knowledge, we also looked at when clinically things were occurring, and we found that when we were doing carotid artery stenting, as those who do this will agree with, when you do the procedure, especially during the post-dilation part of the procedure, if the patient is awake, that's where you start to see them get symptomatic. They'll start to yawn or become aphasic or stop being able to squeeze their ducky. So it appeared, putting all this together, that the procedure aspect of the 30-day carotid time frame was the most important for the risk of stroke, and within the procedure was specifically this post-dilation phase where the maximal risk seemed to be occurring. And so we needed a way to assess whether this was true or not, and the best way to assess whether or not there is embolization occurring during the procedure is not by clinical events, because clinical events oftentimes are few and far between, but MRI is very sensitive, especially DW MRI. So we looked at DW MRI, and we found that if you look at the incidence of new lesions after carotid artery stenting with an MRI done between 24 and 72 hours after the procedure, with a single distal filter approach, regardless of what filter there was incidence of new lesions in the brain of between 80 and 90%. Now, to be sure and clear, this does not mean 80 to 90% have strokes, but as a marker or a surrogate marker of embolic protection, this was a good way to assess that. And even with proximal occlusion or with mesh-covered stents, we had between 45 and 50% incidence of new lesions after carotid artery stenting. However, if you look at flow reversal by TCAR or endarterectomy, the number is more in the 17 to 18% range. So the question we had was, what can we do such that with carotid artery stenting, we start to approach the same levels of DWMRI lesions incidence with carotid stenting as we have with endarterectomy and with TCAR, and that was a goal that we wanted to get to. The thought being that if we can get that done, then that would hopefully address this higher risk of minor stroke that was persistent across all segments of carotid artery stenting. So in designing this optimal carotid artery stenting, we felt that we wanted an optimal embolic protection system, which would result in a low 30-day stroke rate and low long-term stroke rates. We wanted an efficient system, 6 French compatible, nothing too large. We wanted something that minimized the risk of debilitating major strokes, stent thromboses, neurological deaths. And also, if we're going to do this, let's come up with a stent that's conformable such that it can work with tortuosity segments as well as severe calcification, because right now you sometimes have to choose between the two. And obviously we wanted good long-term results as well to maintain the low risk of restenosis and TLR we already see with carotid artery stenting. So as we dived in further, we further recognized, as we looked at the data, that 90% of all particles that are released during carotid artery stenting during the procedure itself, and especially during post-dilation, 90% of particles that were released were less than 100 microns in size. Okay, so keep that in mind. And we also found that all the embolic protection strategies that currently exist with carotid artery stenting have either pore sizes or cell sizes that are more than 100 microns. So if you look at the filters that we use, NAV6, NG-Guard, filter wire, spider, all of them have pore sizes more than 100 microns. And even the mesh-covered stents have a dual layering, but the cell sizes on those stents are between 165 to 500 microns. But if 90% of particles that are being released are less than 100 microns, maybe those are still getting through, and maybe that's why we're seeing this higher risk of DWB MRI lesions. So we designed a new balloon, which had an additional feature on it, which was an integrated filter. And the filter is designed such that the physician can open and close the filter using a knob on the handle, and can therefore expand the filter to custom fit each patient's anatomy and create a full seal. So there's no gutters or alleys around the filter. And then the filter itself had 40 micron pores, again, based on this knowledge we now had that 90% of particles were less than 100 microns. We chose 40 because anything less than that, you start to get white cells and blood products to start getting impacted. So this was what we called our IEP technology, or Integrated Embolic Protection Technology. And with this technology, we did in multiple clinical trials using this balloon only for post-dilation. And what we told physicians in the clinical trials was use whatever technology you want to begin with, your filter of choice, your stent of choice, but when you post-dilate, use this balloon with the integrated filter with 40 micron protection. And multiple trials were done, including one trial with 33 patients with MRI in pre and post. And what we found was that the incidence of new lesions in those patients who underwent carotid artery stenting with this additional filter was 21.2%, now starting to approach what we wanted to get to, which was the endarterectomy and TCAR-like results at 17 to 18%. Again, suggesting that improving embolic protection during the procedure should get us down to where we needed to in terms of embolic risk. So then, once we had this two-in-one device and we knew that we were approaching something in terms of better results with post-dilation, we then went to the next step and added a stent onto that to make a three-in-one device to make it even more efficient. And we just added a stent onto that, a self-expanding nitinol stent. The stent is closed-cell but very flexible, as you can see over here, kink-resistant to 270 degrees. And it also has very good radial force and crush resistance, so it can work in tortuosity and can also work in severe calcification, such that the current decision-making process that sometimes occurs where you have a stiff stent that can create kinks, or a flexible stent that does not have good calcium performance, that choice would hopefully go away. So this device called the NeuroGuard was studied in the Performance 1 and Performance 2 trials. The Performance 1 trial was an EU feasibility trial with 67 patients done in 9 centers in Europe. And in this study, followed out to 1 year, there were 0 strokes at 30 days, 6 months, and 1 year, and no restenosis at 1 year. It was a feasibility study, small numbers, but based on this, we then moved forward with the Performance 2 study, which was a pivotal US FDA study. While it was a US study, there were 24 sites in the US, 8 sites in Europe, 305 patients. The PI globally was Bill Gray, and the European PI was Ralph Langhoff. And the primary endpoint was 30-day death stroke MI plus ipsilateral stroke from day 31 out to day 365, with patients being followed out to 3 years. Based on characteristics over here, 20% of patients were symptomatic, but the key things here, 43% of patients had diabetes, and 66% of patients had either moderate to severe calcification, 34% of which had severe calcification by core lab analysis. 30-day outcomes with this showed that all stroke at 30 days was 1.3%. There were 4 strokes, all 4 were minor strokes, all patients fully recovered within about 36 hours from these events, and there were no major strokes. In a protocol analysis, it was 1%. There were no contralateral strokes in this, there were no neurological deaths, no stent thromboses, so really good results at 30 days. Following that out now to 1 year, adding on that ipsilateral stroke from day 31 to day 365, the number became 1.8% at 1 year, an intention to treat analysis, and 1.4 in a poor protocol analysis. That was essentially 1 additional minor stroke. Again, the patient fully recovered. There was a patient with COVID. And so in total, at 1 year, 5 minor strokes, no major strokes, all patients fully recovering. Data are now have been presented out to 2 years. Out to 2 years now, still no major strokes, no neurological deaths, no stent thromboses, and in-stent restenosis at 2 years of 3.9%, which is really consistent with all singular nitinol stent technologies that have been evaluated to date. So how do you put all this together as compared to other trials that have been done so far? So if you look at the Sapphire data many years ago, the carotid stenting data, 8.5%. The surgical arm was 8.3%. In CREST at 1 year was 6% for stenting, 3.9% for the endarterectomy arm. And now you look all the way to the right side, you find with this integrated embolic protection technology, 1.8% risk at 1 year with really good outcomes. So in summary, what we set out to do was to address this risk of minor stroke by addressing microembolization that's occurring and not being captured during current carotid stenting procedures, by optimizing procedural embolic protection to capture particles more than 40 microns, resulting in a very low stroke rate in both the Performance 1 and Performance 2 trials. At 2 years, the outcomes have been excellent with no major strokes, stent thromboses, neurological deaths, and restenosis rates have remained low. The stent is conformable, and so therefore there's no choice that needs to be made in terms of radial strength versus flexibility. The results appear to be better than endarterectomy in high-risk patients and comparable to TCAR, but longer-term registries are, of course, needed. This system is also being studied for a TCAR approach in the Performance 3 trial, and those data will be presented at VIVA in about 6 weeks. Thank you.